Welcome to safety. Safety is the basis of Block 1. It is the foundation of nursing, and it's something we strive for every day as nurses. Safety is paramount concern that underlies all nursing care, and patient safety is the responsibility of all healthcare providers. Safety is so important to nurses because safety and security is a basic human need. Humans need to be safe and secure to survive. It is a focus in all healthcare facilities, as well as in the home, workplace, and community. As nurses, we are always looking at ways potential hazards will affect our patients. Safety is such a huge concern that the government dictates safety goals every year. Part of these safety goals, and our role as nurses, is to consider the developmental level, lifestyle, mobility, sensory perception, knowledge level, communication ability, physical health, and psychosocial state when addressing safety concerns with our patients. Like every skill we do, from vital signs to head-to-toe assessments to medication pass, it's all rooted with safety first. Every developmental stage has its own risks, from being 1 minute old and being one breath away from death. For Block 1, we'll focus on adults and older adults, so the safety concerns related to these two age groups are what we're going to focus on. Adults have several safety concerns, the first being drug, alcohol, and tobacco use. All substances we add to our body that may affect our safety. For example, marijuana use is at an all-time high, and nicotine and vaping use has increased significantly. Opioid use and binge drinking have decreased since 2018, but still the use of these is still prevalent in adults. All of these substances can affect our thinking, functioning, and decision making. Another safety concern in adults is intimate partner violence. This can include physical, sexual, stalking, or psychological abuse. Sadly, it's not uncommon for one or more of these to occur together. Women are victims more often than men, but not by much. Men just don't report it as much as women. As nurses, we're often the contact person abused people open up to the first when they come to see us for any kind of abuse or they come into the hospital. Usually we're the first people they're going to open up to. At work, adults can be exposed to harmful chemicals, loud noises, pollution, heavy machinery, and sleep deprivation, all of which can affect the adult's safety. At home, adults are at risk for falls, fires, poisoning, and carbon monoxide poisoning. So what can we do to help adults who are not safe? Well, we can remind them that the effects of stress on lifestyle and health and how stress is going to make them sick. We can encourage them to enroll in defensive driving courses. We can counsel them about unsafe health habits like drugs and alcohol. We can talk to them about the way to leave abusive situations. We can talk to them about ways they can prevent workplace injuries like wearing ear protection and getting adequate sleep. At home, we can encourage smoke detectors, carbon monoxide detectors, and fall prevention. Older adults have safety considerations that are based on declining physical and mental health. First, they are at high risk of falling. 1 in 4 older adults will fall each year. Half of these people will tell their providers that they fell. 1 in 5 will involve a serious injury like a fracture. The major causes of falls in the older adults are slippery surfaces, clutter, improper footwear, and balance and gait issues. We will discuss causes more in the musculoskeletal lecture. Older adults are at higher risk of motor vehicle accidents due to vision changes, decreased reaction time, altered judgment, and muscle weakness. They're also at higher risk of polypharmacy issues and abuse, and we're going to talk about both of those things more in depth in our aging lecture. What can we do to help the older adults be safe? We can identify safety hazards in the environment and modify the environment as necessary. We can encourage defensive driving courses or courses designed for older adults. We can encourage regular vision and hearing tests and have the corrective lenses and hearing aids available and functioning. We can make sure their home has working smoke detectors and carbon monoxide detectors. We'll discuss polypharmacy and abuse strategies with the aging lecture. Mobility is another area that oftentimes affects safety, especially related to falls. Anyone who has an unsteady gait, weakness, is an unfamiliar surrounding, or has any supportive or corrective devices like a cane or a walker or corrective lenses is prone to falling. And honestly, most of these affect every patient in a healthcare setting, which means most patients are at risk of falling. People who have previously fallen, are taking medications that affect their heart or brain, using assistive devices of any kind, are weak, or use drugs and alcohol are at higher risk of falling. Again, most of these can occur in our patients. Things we can do that help decrease the risk of falling include making sure that the patient has their corrective lenses and hearing aids and that they function. We educate them on fall risks and prevention. We make sure they can hear and understand us and read any written education we give them. And that we follow up on any requests for using the restroom, pain medication, or food and water. If they have the objects they need, they're less likely to get up, to go search for them, and fall. Another very helpful thing we can do is prevent falls, is orient them to their surroundings and keep the room set up in a way without clutter. We also want to ensure adequate lighting. If the patient knows where everything is in their room, like the lights in the bathroom, the less likely they are to get lost and fall. In addition to keeping the room set up the same way and free of clutter and having adequate lighting, there are other things we can do in our healthcare environment to help ensure safety. One is to be aware of the real and potential environmental situations like falls and putting that knowledge about fall safety into practice. Another major safety concern that we will discuss in incredible detail is medication safety. Medication safety starts with patient identification. Every single patient interaction should include us checking the patient's armband for name and date of birth against our medical record and confirming the name and date of birth with the patient. Every time. Patients move rooms frequently, and we may assume Mr. Smith is in room 220, but he could have been moved to another room. In addition to the name and date of birth, we must confirm the patient's allergies with the medical record and the patient. There are so many medication allergies and latex and tape allergies out there that we must be mindful to make sure we don't expose the patient to any allergens. This is part of our standard protocol. We wash our hands, we introduce ourselves, we check the patient's identity every time. We must also make sure the patient has their call light and bedside table with their items at all times. If they can't get a hold of us or their belongings, then they're going to get out of bed and then they're going to fall. Other safety issues that occur in our working environment is fire safety, alarm management, equipment-related accidents, and procedure-related accidents. Fire safety is a huge topic in healthcare, so much so that you will do annual training on fire safety when you start working in healthcare. Every year, you'll do it. Part of fire safety is having facility policies and procedures on what to do in case of a fire, along with fire drills. The reason why this is required is because healthcare deals with oxygen, anesthetic gases, and medical equipment that use electricity, and those are the things that are necessary for a fire to start and to spread. Alarm management is another safety concern in healthcare. There are alarms for everything in a facility. Alarms that call for help, alarms that tell you someone's trying to die, alarms for emergencies, and alarms for equipment. All of these noisy alarms cause alarm fatigue. And alarm fatigue is when we hear the alarms for so long that we become accustomed to them and we don't hear them anymore. And this is a huge problem because if we don't hear the alarm going off saying that the person's getting out of their bed and they may fall because we become fatigued to it, then that person's actually going to fall. We have equipment-related accidents where the equipment fails and cause harm to a patient, or the equipment isn't used properly by the healthcare workers. You must know how to use the equipment you are using. You could kill someone if you try to use equipment that you don't know how to use. And then we have procedural-related accidents, like giving the wrong medication, transferring a patient incorrectly, or changing a dressing incorrectly. The best way to not have these happening is by following your standard precautions and policies and procedures. If you follow the necessary steps every time, you're not going to injure a patient. Restraints are physical devices we use to limit a patient's freedom and movement because they're not easily removed. There are many types of restraints, like wrist restraints and chair restraints, but anything that limits a patient's freedom can be considered a restraint, like the side rails and even medications. How to determine if something is a restraint? Well, you're going to look at its intended use. If it's something that's made to restrain, obviously it's a restraint. But if you're using the bed rails, which are used to help patients move around in bed, but you're using them to keep them confined, you don't want them to get out of bed, and that's going to be considered a restraint. And if you're doing something involuntarily or against the patient's will, it's a restraint. If we use restraints, please know that it's a last resort for us. We always want to try using alternatives before restraints. Alternatives can be the bed alarm, sitters, family, a busy box, even moving the patient closer to the nurse's station. Anything that distracts the patient from whatever they are doing that's making you want to restrain them. If we do put restraints on, you must have a provider's order, and restraints are not PRN, meaning you can't use them whenever you want. They go on, and if you take them off, you must have a new order. There's a lot of charting that goes along with restraints, and there are major governmental policies that govern how facilities can use restraints. Always, always, always follow your facility's policies and procedures. And if you don't, and your patient has a bad outcome from the restraints, it can become a lawsuit. So what are the potential bad outcomes of restraints? Well, they actually never make the situation better. Imagine being confused and combative and scared and someone ties you down. Are you going to suddenly cooperate or are you going to get worse? These patients fight so hard against the restraints they can rip their skin. They have severe injuries and they can break bones from fighting so hard. They can become incontinent and their muscles can spasm into contractures. They can get depressed and have delirium, which makes their mental state worse. They get incredible anxiety because they don't understand why they're tied down. And being tied in bed makes them a high risk for aspiration and respiratory issues. I've heard stories of patients choking themselves by accident because they twisted and turned in the restraints and choked themselves. And then the worst outcome is they die. And just so you know, if someone dies in restraints, it's an automatic medical examiner's case, meaning it gets investigated legally. So before you choose to use restraints, you better make sure you've used every single option first. And this is the end of safety.